Welcome to Eye to Eye. I'm Camiel Boon, and today I'm talking with Dr. Grazia Pertile about surgery in exudative AMD. You are one of the few surgeons in Europe that perform surgery in exudative AMD. What is it that makes these cases so difficult?
Yeah, there are a number of reasons, to be honest. Starting with the operation time. These are operations who last 2-3 hours. And you really need to pay attention to the details of a surgery, because otherwise you run the risk that you get serious complications, vision-threatening complications. So you have a learning curve. It is very important to be very careful and to pay attention to every detail to get good results. These are probably the main reasons.
How many cases would you think you would need to do or be able to do to keep your skills when it comes to such detail?
It depends on what your experience is about other cases. If you are used to do trauma cases, for example, probably your learning curve will be not so steep, and not so difficult. But of course, the other important thing is to go and see this kind of operations in a center where it is routinely done, to avoid to make mistakes and to have to learn by your own mistakes.
Yes, that can help. And what approaches do you use? I understand that you're using macular translocation and autologous choroidal graft transplantation.
Yeah, these are both good and possible techniques. In fact, macular translocation is based on the relocation of a macula on a healthy area of RPE. So as you rotate literally the retina, sometimes you can have a cyclotorsion. And so usually we do this kind of operations in patients with a poor visual acuity in the fellow eye to prevent diplopia. And the other critical question to do a translocation is that you need an area of healthy RPE pretty close to the CNV, vascularization, because you cannot rotate for 180 degrees the retina, while you can take a healthy area of choroid and RPE wherever you want. So you can take it in the nasal part and transplant it under the macula. So let me say, choroidal grafts give you more freedom to choose the area where you want to do. It has no problem of diplopia, but it needs reperfusion of a graft. And this in some patients can be a problem, and it is, I think, the reason why the visual acuity usually is better after macular translocation than after graft. Although if a graft is well reperfused in a short period of time after the operation, you can have wonderful results with 20/20 visual acuity recovery.
Okay, that's interesting. And so, in which cases do you take the step to macular translocation? Is it only when there's a large hemorrhage, or also even if there is already quite some scarring?
Yeah, there are very few indications nowadays, of course, because in most cases you can treat the patient with anti-VEGF, and you have absolutely to do that if it is possible. The indications are, as said, very limited and include the non-responders to anti-VEGF. It means visual decrease despite 6 or more injections, or RPE RIP involving the fovea. This is probably the best indication, and it gives the best results because it is an acute event and you relocate the retina is still good and gives wonderful results when the fovea is involved. Otherwise, you don't need to do this. And large hemorrhages that cannot be treated with TPA and gas displacement. One crucial point is you can get good results only in patients where you find the external limiting membrane before the operation. So you cannot replace the photoreceptors if they're completely dead, you know, so it is very important to select the patient. So it is not something, but it is useful in chronic cases with scarring tissue and where the outer retina is completely gone.
So acute cases with persistent ELMs.
Yeah, not so. Sometimes it does not need to be acute because sometimes you have patients treated for 2 years with anti-VEGF and then they start losing vision, but the external limiting membrane is still there, and then you can get some results out of this.
Okay, very interesting. And how do you integrate this pharmacological approach of anti-VEGF in this surgical practice? What is your strategy for that?
We usually do anti-VEGF therapy as far as it is possible to do this, and we go to surgery only when you get no result. There is no other choice. Sometimes, especially for macular translocation, you can get a recurrent CMV after the operation, and in this case, anti-VEGF can be integrated with surgery again.
So you don't continue the anti-VEGFs in the period after the surgery?
No. We don't.
So
we don't.
If there's
Unless
a
there is a recurrence of a neovascularization. It happens within 2 years in 20% of the macular translocation and very, very rarely in the choroidal graft group. Yeah.
Very interesting. Thank you. Thank you for joining us. For more information on this and related topics, please visit us at euretina.org.